Okay, can we go ahead? Hi, Richa, can we start?
Yes.
Yeah. Good afternoon, doctors. I am Dr. Rohan from Brinton Pharmaceuticals, and I welcome each and every esteemed delegate on behalf of Brinton Pharmaceuticals to this series of webinars called Master Classes in Vitiligo. Sir, can we go to the next slide? Yeah. Today on 22nd of today on the 6th May, we are having the fourth webinar encompassing the important topics in the management of vitiligo, which the topics are medical therapy and the recent advances in vitiligo. We had our first webinar in December 2021 on non-cultured epidermal cell suspension method. So can we go to the next slide? And then it was followed by the second one in February 2022 on the punch skin grafts, and the third in March 2022 on ultra thin epidermal skin grafts, blister grafts, and hair follicle melanocyte cell grafts. It was attended by participants from India and abroad as well. We thank you for your encouraging response to all these webinars, and if anybody has missed watching these webinars, or if they wish to watch it again, they can always go to the Brinton's YouTube channel and watch these recorded sessions at their convenience. So the next slide. We at Brinton continue to add value in continuing medical education through various educational initiatives and for the benefit of medical fraternity. Today we have stalwart with us to guide on this subject, Dr. D. Ravichandran sir, very renowned subject matter expert and senior consultant dermatologist from Apollo Hospitals, Chennai. Dr. Ravichandran sir is one of the leading and well-known vitiligo and pigmentary disorder specialists of India. His work spanning more than 35 years in the field of dermatology has been appreciated all across India and beyond. I will quickly go through the CV of Dr. Ravichandran sir. He has graduated from Madras Medical College in 1980, followed by a diploma in dermatology in 1984. He did his MD in 1989. He has been postgraduate teaching faculty in Department of Dermatology at Stanley Medical College, Chennai for more than 15 years. Dr. Ravichandran sir has got trained under Professor P.N. Behas Institute of Dermatology, New Delhi. He conducted many dermatosurgical workshops for dermatologists and also conducted many CMEs. Has been examiner for fellowship in dermatology surgery at Bangalore Medical College and Rajiv Gandhi Medical University. Has conducted many national and international presentations and publications as well. He has been co-author in the dermatology chapter of Apollo Hospitals textbook of medicine. Has been conferred with Dr. Patrick Estudiant First Oration Award. Also, Dr. Ravi was awarded as Best Dermatologist Chennai in 2017. He has special interest in vitiligo surgery and cutaneous oncology. Dr. Ravichandran sir is life member of various prestigious associations like Indian Association of Dermatologists, Venerologists, and Leprologists, Association of Cutaneous Surgeons of India, Indian Medical Association, the Hair Research Society of India, the World Vitiligo Research Foundation, New York, USA. Dr. Ravi Chandran sir has also conducted many clinical trials with Apollo Spectra. After this session, if you have any questions, please type in the comment box given below the video, and we shall try to accommodate as many questions as possible within the given time frame. And if any questions remain unattended, you can contact Dr. Ravichandran sir on his email ID, that is raviskindoc@gmail.com. That is raviskindoc@gmail.com. After this introduction, I would like to hand over the session to Dr. Ravichandran sir. Over to you, sir.
Dr. Rohan, good afternoon to each one of you. Thank you for your kind invitation to do a series of programs on this master classes in vitiligo. Vitiligo is disease very close to my heart. I've been working on this topic for so many years, spread over 30-35 years or so. I'm very happy to deliver this talk today, and world over, and particularly in India, all the dermatologists who are given so much importance to this disease to get bringing the color back in these vitiligo sufferers. So I would be talking to you about the new advances in the medical management today, maybe touch upon on certain things, new development which in the field of medicine and surgery as far as the disease concerned called the vitiligo. You know, the vitiligo has taken the journey through ages. You know, it's not very new disease. So we have seen this literature dating back to 3,000 years ago and is described as ancient civilization by various names. The disease was confused with leprosy, which led to the stigmatization of vitiligo sufferers. You all know that even today, vitiligo causes so much agony, and then stigmatization is still there. So we have tried our level best to identify and solve this issue, but still, and this is a burning issue that I don't know how we are going to take up this topic of removing this vitiligo from the stigmatization. Hippocrates was the first to report that vitiligo is easier to treat at the onset of the disease rather than late in the course. So this is a very apt description by Hippocrates that we always start in active spreading vitiligo. We manage them with immunosuppressive treatment. Vitiligo was recorded as a Sweta Kushta in Atharva Veda dating back to so many years ago. Even Papyrus recorded two types of pigmentary loss, vitiligo and leprosy in 9500 BC. The final word vitiligo was coined by Celsus, which was derived from the word vitilius, meaning flesh of the calf. So these are the small things which I could manage through the previous history. Very interesting, no? So that shows that it is still a disease which is there. We are not able to get some answers, but we have come out with some good theory as well as research on this topic. Historic disease is an acquired depigmented disorder with selective destruction of melanocytes with multiple etiologies and polygenic inheritance. It affects 0.1 to 3% of the world population. The impact of vitiligo in darker population is greater owing to the pigmentary disfigurement affecting significantly the quality of life. It is often confused with leprosy and produces social stigmatization. So where are we now? We are still in the early stages, or we have got a lot of advancement? Yes, definitely. Though we could understand the single melanocyte cell, the unicellular cell which is derived from the neuroectoderm, travels down to the basal melanocyte layer as well as into the hair follicle basal cells and producing its melanin pigmentation through series of melanosomes, stage 1, stage 2, stage 3, like this. So finally delivered to the adjoining keratinocytes. We call this as epidermal melanin unit, which is discovered by coined by Fitzpatrick. So this is a very interesting cell, and if it produces good amount of pigment, and it's okay, if it's getting destroyed by some process, it results in a depigmentary condition called vitiligo. To define a disease, it's very interesting that this is the most common disfiguring depigmentation of the skin characterized by acquired white patches with an unpredictable course. Yes, definitely. We sometimes treat these patients and then even with generalized, we get a good response, but after a few years, it recurs again. It affects, as I told you, 1 to 4% of the world's population. It's a multifactorial orphan disease that affects a minimum of 35 million people world over, yet no satisfactory therapeutic solution exists. We know that it is caused by an autoimmune phenomenon because its occurrence with other autoimmune disorders like thyroid disease, most common association is autoimmune thyroiditis. We do have psoriasis. We have so many genes have been isolated. The chromosome aberrations have been given the loci there. It's all and then now the latest aspect of the pro-inflammatory cytokines, all these factors have been unfolded now. It's very clear that how these melanocytes gets destroyed or autoimmune process really inhibits the melanogenesis has been clearly understood, and now new molecules are targeting on these JAK2 inhibitors. Humoral pathway. We all know that circulating antibodies produce complement-mediated damage and cell-mediated cytotoxicity. Antibody against melanocyte cytoplasmic antigens are generally detected, but it is not feasible as a biomarker to identify these. And we have seen quite a number of that circulating antibodies in a patient with melanoma who can develop a vitiligo at a later stage. Maybe that might give a small kind of a protection because there is an antibody against the melanoma cells, but it also can be shared by the normal circular melanocytes residing in the patient's skin, which also gets autoimmune destruction, thereby resulting in a vitiligo. So vitiligo in a patient with melanoma maybe carry a small indirect prognosis, so good prognosis. Cellular immunity has also been very clearly sourced that it is circulating melanocyte specific cytotoxic T cells which liberate cytokines and pro-inflammatory cells which goes and attacks the melanocytes. As I was just telling you, the common associations is autoimmune disorders like thyroid disease and antithyroid. Actually, this is a very interesting that particularly in pediatric age, one has to really do this workup that though the thyroid profile, this peripheral blood may be normal, please do assess for thyroid antibodies in those active young vitiligo patients. It is also associated with insulin-dependent diabetes mellitus, Addison's disease, systemic lupus erythematosus, pernicious anemia, autoimmune polyendocrinopathy, inflammatory bowel disease. Of course, this is very good associations. We do see these associations, and maybe correcting these disorders may help in controlling the spread of the active stage of the vitiligo. It has got many phases. Just to show you that for the beginner or for postgraduates, how this disease can look up. So you see a small young boy with a segmental patch on the right side of the face and nose and upper lip. So you can see some spontaneous treatment, repigmentation macules, which are there probably with medical therapy, or even spontaneous repigmentation do occur. Probably this is following some treatment, I do not know, but this is the patient which came to me. It's very interesting. Segmental vitiligo in children behaves because it causes so much of psychological. The child is not concerned. The parents are a little worried, and then probably the mothers are very worried, particularly if she's a young girl. And it also become slightly large, and everywhere it can spread, and it can be confined to the lip, or it can be there in the dorsum of head. It can be in the lip vitiligo, segmental, generalized vitiligo. We have a classification called a non-segmental and segmental vitiligo. Yes, what is the basic pathomechanism involved in the vitiligo? It involves a chronic loss of melanocytes in the depigmentation. Of course, we all know that it starts as an insidious onset and proceed to have a depigmented macules and patches generalized all over the body. To understand the role of medical and surgical treatment option one we are going to choose, before that we know that the macules could pass through two stages. The first stage is the reversible with partial melanocyte sorts. So as you can see here, this is a normal skin containing melanocytes, and in this vitiligo, the first stage, the melanocytes are partially getting removed, and then but there are a few stray melanocytes which are persistent, which are active and which are stable. So this is the stage where medical treatment will be very effective. So we have an array of medical treatment. I would like to brief you on these options available to treat with medical treatment about depending upon the type and the stage of vitiligo. The second stage involves an irreversible loss with total melanocytes loss. Okay, this is the one where we are able to see the absolutely no melanocytes in the depigmented macule, as you can see in those photographs which I showed you. That means these are the areas which medical therapy will never repigment these patches because there are no melanocyte reservoirs. So to get a hair follicle regeneration through phototherapy, narrowband UVB are targeted, you will not find any success. So that we need to go for a kind of a surgical treatment, which we've been discussing all these months. Anyway, at the end of this lecture, I would like to show you some slides, those who have not attended the slides, so that for completion's sake, I will also take you a small course of few slides on the surgical treatment, which are currently available and popular all over India, thanks to our professors and our teachers and our Association of Cutaneous Surgeons of India, where we have taken up this project of surgical treatment for vitiligo across every medical college in India. Yes, this is, of course, we all know that there are genetic factors, neural factors, immunogenic factors, and oxidative factors. This is all results in the melanocyte apoptosis, and this is the reason that I have heard that few patients who have developed post-COVID in this COVID period also triggered vitiligo. There are one or few papers available on this new onset of vitiligo following COVID infection. That means it may be operating through its immune process. As I told you, it has got many factors which goes and involves the melanocytes in the form of the sheet anchor is autoimmunity. Then we have the oxidative stress and intrinsic defect in the melanocytes and the cytotoxicity and sometimes the neural mechanisms which was suggested earlier for the segmental vitiligo. Acetylcholine-like enzymes. I don't know whether it's still viable or not. So there may be, maybe we'll look into that segmental vitiligo wherein it can play a small role, but it's still not been clearly defined. These are the pathomechanism which results in depigmentation of the skin. Yeah, this is the non-segmental vitiligo. What really happens here, the melanocyte defective addition, then the loss of density, as it's available very quickly. What is happening? It goes into the vitiligo macule, or it can be an immune process. So all these things are known clearly, but this is more of a theoretical possibility, but it's not may not be applied on the clinical scenario. Yes, as I told you, oxidative stress, and of course, there are one or two papers which are available just to tell you that. Yes. So we are talking about those days, melanocytoregy, apoptosis of melanocytes, and the immune response. Three joining together results in the melanocyte salt in the particularly non-segmental vitiligo. Vitamin D is being talked about in any part of autoimmune disease. It's supposed to build up your immunity. That's why we talked about COVID infections and vitamin D deficiency. So vitamin D also plays a major role in these patients, correcting these patients' vitamin D deficiency while treating these patients. Medical therapy definitely will help in the long way. It may not be as a monotherapy. Maybe if there's a deficiency of thyroid hormone and vitamin D and other vitamins, one has to start these medications so that there will be a good response. Diet, of course, we generally ask them to give take everything, food, all this not very much concerned, of course. So always we take a diet which is full rich of proteins, vitamins B12, particularly iron, folic acid, copper, the minerals. So minerals copper was thought to be earlier days, no? So everyone started using copper because it is involved in the process of the tyrosinase enzyme synthesis. So again, I was just telling you, reduced levels of B12 folic acid has been seen in these patients with vitiligo. So before we proceed well, we need to identify, define this classification, and then it helps you to assess this patient. There are two types, the generalized one and the segmental one. It can start in the lip and the fingertips, but it can become generalized. The picture on the right side is hair dye application. Chemical toxicity, we have not talked about chemical toxicity, which can cause melanocyte apoptosis. So this is the reason that the lady has developed PPD-induced depigmentation. Onset of new vitiligo lesions can be prevented in some cases by having the patient eliminate the majority of repeated trauma to the skin. Of course, Kubnerization. How does this Kubner phenomenon can probably the injury can expose the melanocytes to the circulating T cells? Maybe the circulating T cells circulate, and maybe that is why this concept is to be taken into account, because the injury to be avoided in a patient with an active vitiligo. We were talking about the Kubner phenomenon. Kubner can be one of the triggering factor in vitiligo. We have seen quite a number of patients who developed vitiligo after poor treatment. usually UVA based, no? So that's called the sun sensitive vitiligo. Please make sure the patient is not responding to phototherapy. Please avoid giving phototherapy. And it's a telltale evidence that this patient has got vitiligo only over the sun exposed sites, particularly on the forearm, not in the arms, not here, there. And you can see here on this exposed site and of course the lower lip. So sun sensitive vitiligo is a new concept which my professor, Dr. Professor Patrick Yasudayan has taught us, our teacher. So we learned so much from our teachers like Dr. P.N. Bell, taught me a lot of these things on vitiligo. The father of vitiligo surgery in India is Dr. Professor P.N. Bell. And of course, my Professor Patrick Yasudayan and my colleagues and professors and friends and patients have enabled me to do this topic for the last 30 years to identify and able to do justice to certain group of patients in relieving their agony and the depression and this psychosocial impact of the disease on their mind. Segmental and non-segmental. We know that segmental is the one of the thing which is refractory to treatment, and it has to be generally managed by any surgical procedure which you plan to do it. It's very easy and technique. I will try to show you the latest update on how the non-cultured epidermal cell suspension is done. I did 2 procedures today. Non-segmental vitiligo classified as common, mucosal, acrofacial, which is most difficult to treat. The acrofacial vitiligo is the most resistant to treatment. And then we have mixed do occur and the small areas of focal vitiligo. There are unclassified vitiligo, follicular, gutted vitiligo, punctata, like your PUA induced punctate vitiligo. All these things, new elements, disease manifestations do occur. Drug-induced vitiligo, we have seen drug-induced vitiligo in many patients. Okay, this is very classically, we all know that how you milk white patches involving multiple parts of the body in a symmetrical distribution. That's the common vitiligo. Acrofacial involves the face, hands, legs, and feet, including the nipple areola and the genital mucosa in men and women. Focal small patches here and there distributed, but generally respond well to medical treatment. Very unlikely that proceed to generalized stage. Yes, we talk about universalis. How does it more than involves 80 to 90% of the body surface? And then the mucosal vitiligo can remain in the lip mucosa or genital mucosa, but it generally may not spread to other areas. It's interesting that why this is happening only in this mucous membrane, not going into involve the skin surfaces, and how characteristic is this? The lip vitiligo also patients do have on the fingertips and toe tips, acral area. This is a very immune pathway mediated. We do not exactly understand why this is very unique. That we always, when you see a patient with vitiligo on the lips, we need to look into these fingertips for small early signs. So that might give a lead that you need to give a little more good treatment options so that this doesn't spread. But any vitiligo which is going to be there on the lip and the acral area are going to spread, and then we have treatment options to stabilize this disease so that it doesn't become larger in those affected areas. Punctata, I will skip this slide. Different types, people have developed segmental vitiligo at birth and subsequently extensive lesions, segmental followed by vitiligo. And then there are interesting observations following along the Blaschko's lines, response to Naraban EVB treatment. Maybe segmental is, we have not seen much success. And then whatever it is, once a consultant have seen the course and the interest in showing with how the disease behaves in the long run, you can easily predict. The patient comes and sits and asks you, show you the picture or maybe the skin surface. So doctor, they worry generally. We need to classify them, tell them that we have our experience. Okay, this is going to become more. This is going to become a generalized vitiligo, or this is going to become very stable. I learned this from Professor Bale that we already used to classify this disease as V1, V2, V3. V3 stage is one, the border edges are well defined and dark and pigmented with a small pigmentation from the edges creeping on to the depigmented. That's a very stability of the disease. He always says clinical stability And now we talk about stability of the disease in a nice way. And both Devinder Prasad and Somesh Gupta and our team from IASI has done an excellent defining this stability and when to involve medical therapy and surgical options in these patients. The most common, particularly seen in children, and it can occur any place, particularly commonly seen over the face, eyebrows. If it involves the eyebrows, it can also result in a leukotrichia of the hair. Though we are able to do very good treatment with the segmental vitiligo, sometimes these white hair, the leukotrichia hair, are very difficult to treat, and you can go for a small follicular hair transplantation, or sometimes if the basal melanocytes are repopulated, it can migrate retrograde and then repopulate the basal hair follicle to get your skin hair darker. So this is the one, and then which I showed you very nicely. This long years ago, I did a small ultra thin graft. The complication is here is the darker color, though it's smooth, uniform, and then maybe a peri-graft halo. Nowadays, we are able to manage it much better. This is the beginning procedure which all of us started doing those days with the epidermal graft from Dr. Pay and Bell. Yes. Imatinib, no, drug induced. I was just telling you about proton pump, and imatinib can cause vitiligo. Proton pump inhibitors induce vitiligo by affecting the intramelanosomal pH switch, which is essential for normal melanogenesis. Trauma can happen, infection can happen, injury, as I told you, phototherapy, sunlight exposure can injure. High amount of emotional stress. Probably, I don't know whether about the COVID time vitiligo was generated because of multiple factors. Immune system derangement as well as the emotional strain the patient go through the moderate to severe COVID infections. Yes, we all know that how quickly we can manage is a very important tool, clinical tool to assess the stability, the disease progression, and how the outcome of the medical and treatment options in these patients with vitiligo. Please, all the postgraduates must see in these patients. Full skin examination is needed, specifically for recent Kubner phenomenon. So he is not a candidate for any kind of a procedure. The Kubner has been identified, the cause, avoid those Kubner phenomenon. I was just telling you the friction, the trauma, the phototherapy, undue sun exposures, and drug induced. The most disturbing condition is childhood vitiligo. As I was just telling you in the beginning, that the median onset of age is 6 years or so. Females are more common. Members of the affected family are high incidence. Sometimes they do have vitiligo. Segmental is the most common one. The face and neck is the most common. Kubnerization is very common due to playfulness and high mobility. 25% have got scalp vitiligo. Please look at the white hairs, suddenly gray hairs, premature graying. Look at the scalp skin if they have a small vitiligo patch. Maybe the white hairs, maybe a foreigner for development of a white patch on the scalp skin. Please look at it, and then maybe we need to combine both the treatment of the skin vitiligo and the hair follicle vitiligo. Though it's stable and progressive, repigmentation rate is higher than adults, especially in our countries. I'm just telling you. This guy has got segmental vitiligo, as you can see the eyebrow hairs have become depigmented. And number two, this guy is a young boy, a very young, sweet-looking boy, came to me many years ago. He had a congenital melanocytic nevi. Then he had a peri-halo pigmentation called halo phenomenon, called Sutton's nevus or vitiligo around the mole. And after a few years, he started developing vitiligo at the distant sites. Maybe the auto antibodies against the nevus cells understands the normal-looking melanocytes and then goes for a autoimmune phenomenon destroying the melanocytes. So this is the one. Please look for halo nevi in any patients who got a generalized vitiligo. My option will be able to pick up a halo nevi, just try to remove it with the punch graft, so that don't allow the T cells to actually halo nevus response. The nevis get destroyed, removed by its own process, but don't too long to wait. Too long maybe waiting. Probably the T cells have got talk to each other and then talk to the other melanocytes and have a fight with the other melanocytes. Yeah, we don't give steroids in young vitiligo. and because it causes Cushing's disease and then retarded. Of course, parents are very aware that don't give topicals, even strong topical steroid. Narrowband UVB is very, very safe. Surgical therapy is not an option, but sometimes the child is a boy, young school boy or a girl is about 10 years. We can do, and select cases we can always identify and correct the small areas which are seen visibly on the surface skin, particularly facial vitiligo. I'm not talking about, I'll just go to the recent advances. There are 1 or 2 new molecules which are also available. How far we can choose these in these patients with childhood vitiligo? Yes, treatment, of course, segmental we all know, identify them, stability, and then go for, if it's not repigmenting, go for surgery. Camouflage cream plays a major role for a school going girl and a child, and this is how we classify them. Unresponsive phototherapy, narrowband immunosteroids, all those things classification is available in our textbooks. Pregnancy and vitiligo, adverse events outcome in pregnancy. Photochemotherapy is contraindicated in pregnancy. Narrowband UVB is a safer option. I just finished about melanoma. The patient has got a melanoma developing vitiligo. That may be a good prognostic marker. Yes, so always we have a computer generated sheet so that we mark these patches. Even during phototherapy, we tell them, oh, these are the places where we have different area of involvement, Wallace rule of 9, Ludbro, so many things are available. If you're going to really, for postgraduate, going to prepare a thesis on medical therapy, these slides are more important to see. There are a lot of scoring system, VASI scoring system. This is also very useful to identify the treatment prognosis and treatment improvement and switch over to what type of treatment you want to do, whether to continue your treatment option, which showing the good reduction in the VASI score system. Extent of residual pigmentation, 100% no pigment is present. Disease severity indices and the treatment out. This is a very important slide because it classifies them so that you do not take the same treatment, so that you switch over to combination treatment at a later given time. Yes, these are all there in your system. Of course, vitiligo, European BETF is also available. Yes, yes, you can always go through this. It's available in the textbooks and internet. All of us must understand the social stigma, not only on the affected child or a person, on the whole family. It's very important that we talk to them initially, reassure them. Once you keep talking, I think they will definitely understand, because regular monitoring, regular treatment with a consultant is the most important, because he need to modify his tools to identify and treat whatever best he can do. Suppose if you keep on switching the therapy like other alternative therapies too, then it is very difficult to manage. It's because low self-esteem, depression, create social barrier, job discrimination is very common, and it's also cause psychological impact. The studies and the performance, cognitive therapy. All this is very important that we need to educate and do some cognitive and behavioral therapy. A support system is very effective, so prepare them to accept the disease and maybe use a camouflage for the exposed site depigmented patches. Yes, I was just telling you how the segmental vitiligo. I was just telling you only leukotrichic hair. This boy had no other, I don't know, white forelock, but I opened that there was a small patch of vitiligo. So the different clinical presentations in vitiligo. This is a comorbid disease. It can be associated with, as I told you, with many disorders. Coming to the topics of treatment today, very vast, very extensive. The olden therapy still holds good. Newer options are available. We also started using the newer modalities of treatment. So this is to give you a small brief on what are the things available in our therapeutic armamentarium. The topical and systemic, and the phototherapy. These are the 3 options are available. Topical, we have topical corticosteroids, topical calcineurin inhibitors like Tacrolimus and Pimicrolimus, topical vitamin D3 analgesics and calcipotriol, and topical Soralan, topical Bathkuva. Slowly, Soralins are becoming a little obsolete because of its toxicity, and then side effects. So we always stick to topical steroids if it is a small focal vitiligo. Oral systemic treatment are very effective, particularly in fast spreading active vitiligo unstable. We give oral corticosteroids in the form of different regimens are available. And we have good rich experience from India that Professor Pasricha, if you remember, one of our teachers and well-wishers, so those days from AIMS. So he's the man who really arranged to give us how this mini pulse steroids work in a generalized vitiligo, as well as the pulse therapy in pemphigus group autoimmune blistering disease. I think we always pay our respects to Professor Pasricha. Immunosuppressants are used, particularly methotrexate and then azothioprine. But I have my own reservations because you can give, but under close modification, monitoring. Phototherapy, PUA was there initially. We talked about PUA salt derived from the sunlight. We give 0.6 milligram of Sora 80 MOP and told them to go to the sunlight in the terrace or everywhere and stand for 10 to 15 minutes. And then the PUA chambers came. It also contains narrowband UVB nowadays. Targeted phototherapy in the form of excimer lasers and targeted therapy is also available to treat small areas of vitiligo, particularly post-procedure melanocyte, non-cultured epidermal cell suspension, then which can be easily followed by a targeted excimer laser or phototherapy. This is just to give you a small glimpse, bird's eye view about what one can take and then start prescribing. So many new products came and still time tested, and it has got its little low evidence. And kaolin, phenylalanine, pseudocatalysts, and placental extracts. Fibroblast growth factor came, antioxidants, minocycline, other diseases. These are the one which you can treat as an off-label uses, but generally I confine myself to evidence-based therapeutic options, whether both medically and surgically. If the disease is not coming under control, becoming stable, we plan to go for surgery. And before you plan your surgery, we need to classify them into a tissue graft and a cellular graft. As I told you, the 3 sessions we had was an excellent program on punch grafting, suction blister, split thickness graft, and hair follicle grafts. Cellular grafts are becoming talk of the town in India everywhere. And this is called the non-cultured epidermal cell suspension, or most sought after, and all of us have started training our postgraduates, young assistant professors, and every medical college, including your consultants in their private chambers. Please do help these patients from your side so that they will thank you, and then we can definitely give our benefit, because dermatologists are the correct person to identify, treat this condition called vitiligo. Yes, as I told you, topical monotherapy can be given. Side effects are very common. Low potency steroids before 2 years, super potency steroids after 2 years of age, minimum 4 months, atrophy and hirsutism. You can always combine with the topical UVA, topical PUA. This is always, we do that in those situations. Yes. Calcineurin inhibitor. The advent of this and this molecule, though it has been used mainly for atopic diathesis, but off-label uses for vitiligo is the most usage, which all of us have seen. That Tacrolimus remains one of the sheet anchor, because it acts like the way like corticosteroid, but without its side effects. Small vitiligo macules in the exposed sites, very external. Only question is burning and stinging, particularly in children. That's why we prefer to give Tacrolimus. And it has also been approved by the FDA. You can see this response. You can combine with targeted or narrowband UVB. There are few studies which are available from dating back to 2004, but still all the literature findings have helped us to cure most of our patients. Calcipotriol came in a big way, and we do this topical in patients who do not respond to topical steroids, and give a fair choice of these along with the narrowband UVB or UVA. Puasol, calcipotriol, puasol. There's a lot of combined trial. Devinder Prasad in 1998 did a nice study on this topic of the response to the combination therapy. You can go through the section slides. And the pseudo-catalase, so many things came, but to treat them, it's all depends self-styled and how the patient's response to your therapy. So this is, of course, Jean-Paul Ortoni gave us small treatment options those days. Called it was, I don't know, it's still available. We stopped using this, maybe non-availability, Vitix therapy, narrowband UVB. Then we have the, as is telling you, all these molecules are in use yesteryears. And yes, this is also another good paper from many years from France. So this combination of Tacrolimus 308 nanometer excimer laser, particularly for focal vitiligo. Never forget to prescribe a camouflage cream during treatment. If the response is not good, or that you are not able to do anything, you done partially some kind of repigmentary procedures, it's not complete. At that time also you can give a camouflage so that they tide over the crisis of social anxiety. There are enough preparations are available, and most of these preparations cover up very nicely. The skin color matching is good, but only thing they have to be very careful because it's temporary. If anyone can give a small, at least for a permanent camouflage, at least stays for 7 days. When you wash your hands and feet or face, it doesn't go away, it will be good. So I would recommend the juniors to do some kind of research. Yes, very interesting topic. Recent years, I have managed around half a dozen patients. Said, doctor, I don't want the pigments. Please bleach me. I want to look like an albino, particularly the facial one, the polka dot appearance, confetti-like pigmentation, hyperpigmentation. I think you have justified in using a monobenzyl ether of hydroquinone 20% so that you can remove the existing melanocytes, but these people have to be used 24/7 as sunscreen so that the remaining melanocytes do not get stimulated. Q3 NDI laser also can be done to remove this existing pigmentation. So depigmentation therapy is one of the options, and never forget about this, generally neglected. Mini pulse therapy, I was just telling you, Dr. Pashi's regimen, high dose pulse therapy also can be given. After admitting this patient, you can give methylprednisolone on 3 consecutive nights for a few months so that you minimize the side effects of the long-term corticosteroids. Yes, so this I was just telling you how this is generally done. Yes, this was a talk of the town for a dermatologist boon, and all of us got a phototherapy in our clinic and the hospital's environment, in our teaching institutes. Bath Pova is to be given by Professor Pay and Bell. I was very puzzled when you see a tub full of topical Pova, you will go to the phototherapy, sun Pova. So those are the days where the topical medications are available. And this is very interesting that how the melanocytes in hair roots trying to repigment follicular migration of pigmentation. Yes, this is how it happens with narrowband UVB or PUA. Yes, topical PUA also can repigment. Chambers are available, defined, very safe in particularly in our race. It may be little worrisome in the patients who got a lighter skin because they are prone for skin cancers. They have their own reservations, so make sure that the incidence of skin cancers following PUA is very less in India in our scenario. The defined joules are available. This is usually taken starting dose 100 to 250 millijoules of narrowband UVB phototherapy. 10 to 20 increments at each skin increment to get you a small mild erythema. And then narrowband UVB safely can be given for 6 months to 1 year. Yes, you can see a nice improvement. The young boy with an excellent response to narrowband UVB phototherapy. So we talked about steroids, we talked about topical calcineurin, we talked about phototherapy in different forms, and now we started using JAK inhibitors in the phase 2 JAK inhibitor trial. The cream showed promising results in 157 patients. Then we have the ruxolitinib cream phase 3 trial, been approved by the FDA in US and showed promising results, which is 1.5% cream. Tofacitinib is also selective JAK1 and JAK3 inhibitor, trial on oral 5 mg twice daily and a topical cream. Baricitinib 4 mg daily. All these JAK inhibitors can be tried, but it is yet to be completely approved. But now tofacitinib also is being used as a topical cream, mixing the tablets in a cream base or giving a 1% cream. They say response is very good, particularly facial vitiligo in our refractory cases. I do started giving this because it's not officially available. No manufacturing preparations is available, but across the counter people prepare themselves and then understand. Get a small concern from the patient and then give 1-to-1. So if the response is good, we are happy. So this is the story of medical therapy from ages till today. This is going to be the future, and how we are going to monitor the side effects of the oral and topical JAK inhibitors, and then maybe the good light is there in the end of the tunnel for vitiligo sufferers. So for the newcomers or patient consultants who have not listened to my previous talks, quick brush through just some few slides. I told you yesterday, the previous one. Yes, I must pay my respects to Professor P.N. Bell and Calabella, who really pioneered the technique of test punch grafting to assess the surgical stability before you go for surgery, or stability by our defined criteria. Then we will also skip this, of course. Yes, this is the most important before you venture into surgery: the type, the stability, the sites, the localization, and the cost involved in different types of procedure must be discussed with the patient. The age is also, just telling the children below 10 was usually not done, but we do selective cases. We can do a little age of 8 or 9 or 10. Very easily, I was just telling you, stability is less than 1 year. It was not 2 years, 1 year stability. These patients can take up for surgery. Yeah, this is, of course, we all know that how to identify stability, history of progression, extension of old lesions, Kubner phenomenon, available as mini test grafting. There is no defined marker study in our scenario, so it may not be very practical in a clinical setting. It's very easy. Take 1 millimeter or 0.8 millimeters, put a small 5 to 10 grafts in a donor, some area, in a patch of vitiligo at the edges, and then look for the repigmentation. These are the techniques. Very easy, simple. The beginner students must train first themselves before you go into culturing in the melanocytes. This is the beginning story. Please experience with punch grafts till you master the art. Then maybe you are master the art of doing a melanocyte cell lines in the culture lab, which will be gratifying to the patient and to you. The Orange Robbins punches are available. Segmental graft migration. You have an ultra thin epidermal grafts, can be done with, if you don't have a micromotor or a diamond burr, take a ENT diamond rasp, do dermabrasion and a topical emla local, get the bleeding top layer, take ultra thin graft, a blister graft, and just spread it, keep it for 7 days. Dressing is the most important factor in retying the grafted skin on the vitiligo patch. To show you, 7th day, after 1 month, different patches also can be done. Lips, small areas, lips can be done to good repigmentation. Maybe more than one sitting is needed. You've done everywhere except the eyelids, probably second stage you can do. Suction blister is very effective, simple procedure, but only thing you need to time, start the patient on this, go and finish your OPD, and then come back for the raising the blister. And you see the blister, do a dermabrasion either by any means, CO2 laser abrasion, surgical diamond dermabrasion, or diamond rasp dermabrasion. Put the grafts there. All those areas can be easily done. Yes, this is the 3-stage technique, the kit, the procedure, the post, hair follicles. Yes, vitiligo patients are just differently colored. Let us add color to the life. Thank you very much for your patient listening, and hope our young postgraduates will start the program tomorrow. Thank you, sir.
Yes, sir. So that was great, sir. Thank you very much for your insightful session. Now, with the question, sir, as we had 4 sessions, which included surgical methods as well the today medical methods of managing the vitiligo. Okay. Now, as a young budding vitiligo specialist, if any doctors wants to become, when the patient comes to them, the vitiligo patients, is it the sequence of treatment decided that first they have to try with the oral medication? If it is giving suboptimal results, then they have to move with PUA therapy. And if PUA is also not sufficient, then they have to go to surgical. Or it depends on the patient's readiness and the severity of the disease of the vitiligo.
Yes, initial assessment is very important, history and assessment. And as I told you, how to classify them, place them in the proper slot, and give topical and oral treatment depending upon the disease sites involved. That's it. It's very important that we choose according to the types, and then the response is not there, we choose phototherapy, targeted phototherapy, medical therapy, and you are choosing the newer agents. And finally, if the stability is there and there are no repeat cells are there in the melanocytes are not there, then we look for explain about the surgical options, in particularly young boys and girls.
Okay. Thank you, sir. In sir PUA therapy, especially the Soralens which are used, methoxyline or maybe trioxyline, does it require a really very skillful hands to suggest to the patients, because any dilution in terms of lotion I'm talking, or hyperdosing in terms of that, can it be detrimental while treating the vitiligo patients?
Yes, topical PUA, Soralens was initially used. Even now we can definitely use it, but it has to be diluted because phototoxic reaction, blistering can happen if there's undue sun exposure. But since if it is, we give a small local focal vitiligo in patients who got, we can choose these agents. And then number 2, oral atomopy also given for, as if you have a narrowband if you have a PUA chamber with generalized vitiligo, we always give 0.6 milligram atomopy tablets, 2 tablets 2 hours before that, and then start building up the the UVA dosing, and they get excellent results. And if the response is maybe if the side effects are there, we choose for narrowband UVB. Okay. Toxicity of nausea, vomiting, post-burn are very common with oral atomopy phototherapy patient. That's why we always give this oral phototherapy that is PUA, in the evening, so that they don't go, particularly in India. We have the summer is very hot nowadays. This time I think we are going to experience. These patients also can have a sunburn and feel little odd. So that's why we don't generally give during summer months, particularly late in the evening, so that they take rest at bedtime. And even the next day when they go to the sunlight and work, they have a good amount of sunscreen 2-3 times a day.
Now, the last question I would say, relating to the same what we can say topic, the popularity which the Soralens and PUA which used to have, is it now stagnant, or is it growing, or is it going down? Means how do we see it as per the acceptance by the budding or maybe the practicing vitiligo specialists? In
defined centers, in very well equipped centers, phototherapy, both PUA and UVB, are very useful, effective, particularly in teaching medical institutions, because the number of patients attending is very large. Okay. So this is still useful in a scenario like hospital care.
Okay.
In other phototherapy, of course, Naraban, EVB and PUA can be given, particularly it's limited options in the private setup because newer agents are available now. But when you talk about active spreading vitiligo, one has to use steroids and phototherapy. If, as I told you, phototherapy is a very useful tool to get back the follicular repigmentation. So they stimulate all the melanocytes. I showed you some lot of good pictures that we do see a good response to both PUA and narrowbanding.
Thank you very much, sir. And we are truly fortunate to listen and watch you explain the medical therapy and the recent advances in vitiligo today for the better management of vitiligo. And we are sure the doctor across India and abroad who attended this today's session and also the previous sessions would have got delighted to listen from you. On behalf of Brinton Pharmaceuticals, I would like to profusely thank you for spearheading this complete series of webinars in the master classes of vitiligo, which comprise 6 important topics. I also wish to thank all the delegates for attending the webinar throughout this series. And surely we will come back with the new and interesting educational initiatives for the benefit of medical fraternity soon. Till then, I take your leave and wish you all great health and success. Thank you very much, sir.
Thank you very much, Dr. Rohan. And my wishes and thanks to every team of the Brinton, from the IT team and everyone from your side for completing this